So thank you for these two final presentation. And I think that most of the issues in the first presentation about genetics have been addressed in the past question. And I think that what we can, so one of the main messages that perhaps the past evidence about the association between genetic anomalies, so genetic condition and cardiac anomalies, which we believed in the past is not valid anymore in the era of NGS and WESS. So can you just comment about that? Because I think that's the evidence is rapidly changing on this field.
Yes, we already talked a bit about that in the previous panel discussion. I think really the scope and the phenotypes will change, because what we really have to realize is that infants with genetic anomalies also have a very much increased risk for having complications on the ICU and also not surviving cardiac surgery. So those cases, imagine like 10 to 15 years ago, went into the ICU, were operated, had complications, and then demised on the ICU. And that were cases that in the past never were tested. So I think that the knowledge about the phenotypes of certain genetic syndromes will change. Now the fetal information is added. So if I in the last two to 7 years, I think we started exome sequencing in my center around 7 years ago. We encountered so many single gene disorders where the geneticist did not expect to encounter that specific syndrome. And that is the message that I want to bring about.
This will take time, no problem.
Yeah, is that your experience as well?
Yeah, so I think that one of the major problem with these genetic database is that most of them actually they refer to postnatal conditions. So when we have a geneticist which say, no, this gene is unlikely to do this disorder because it has not been reported yet as a problem. But the fact that the problem is that these databases are postnatal database. I think there is the need for creating a database of single gene disorder related to fetal phenotype too, to what we can see during the scan. And this is something a huge lack. And another problem I think with genetics is that the introduction of cfDNA has allowed a lot of people to think that cfDNA can be used as a proxy of genetic disorders, at least what we see in Italy. So we are not in the most rational country in the world from the scientific point of view. I can acknowledge that, but then in clinical practice, in daily practice, there are many patients who say, so why should I have an invasive? So I did the most expensive test, also looking at the single gene disorder. So why should I have an amnio if I spend a lot of money?
I fully agree with you. Patients think that they have left behind genetic anomalies. And the disadvantage of NIPT is that women and their partners became far more anxious for an amniocentesis than, in my perspective, is needed. They think that with an amniocentesis, they have in a 1-to-2 ratio that they will lose their pregnancy. And at the end of the day, the risk of invasive testing is very, very, very low if you perform an amniocentesis as 19 weeks. And the sense of pregnant women, how dangerous an invasive test is and that I think is really the disadvantage of NIPT, because with the introduction of NIPT, it was advocated, it was advertised that it was to prevent very risky procedures. So I think, of course, NIPT is good, and NIPT brought us very good things and very early diagnosis of 13, 18, and 21 trisomies. But NIPT has also major disadvantages. And I think the most important disadvantage is that it made women very, very anxious of an amniocentesis. And I, in my clinic, I spend a lot of time explaining women what an invasive test can bring them. And I think what I always say in my clinic is what you want to know is how your child is when your child is 8. Will it go to a normal school? Will it develop normally? And for giving a proper answer to that question of parents, you really need an amniocentesis, I think. And a second thing is that what you also mentioned is that geneticists are, and I really do understand, geneticists are afraid of accidental findings, the so-called FUS, variants of unknown significance. And therefore they put all kind of filters on their results. I'm not always that happy with the amount of filters they put on the results, because if you put on too many filters, then we will not discover new genes, we will not discover a new genotypes, phenotype relationships. And that is an ongoing debate between the geneticists and the obstetricians and the pediatric cardiologists. I think that is a very difficult subject, because we should not underestimate the knowledge of our fellow colleagues, geneticists. But on the other hand, putting on too much filters on your results also will cover up unknown syndromes in a fetal presentation.
Yeah, fully agree. And another message is that at the moment we cannot use an IPT as a proxy for basic, and this is unfortunately a lot of people they do that every day.
No, and the picture in my presentation of the 22q11 part of the chromosome that is deleted, and with the different fragments in which the deletion can be, is an illustration that NIPT, I think for the coming years, maybe the coming decade, will not be sufficient to detect those smaller deletion syndromes, which can be as severe as we know.
Well, unfortunately, it's all a matter of communication and of counseling, and we know how difficult the counseling is on this subject, and how difficult it is for patients to understand, especially in settings where they have to pay out of their own pocket for this test, and where the test is offered as the panacea for all the problems. And so indeed, well, it's I wanted to come back again on the Kabuki, because this is indeed a very nice example of how well the new genetic possibilities have revealed a new syndrome that I never heard of it until 10 years ago, and now at all the congresses you hear Kabuki, 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 and who knows, maybe in the future there will be some other association that will come up. It's indeed a very dynamic field where things are changing, and where we have to be aware of the fact that we are witnessing now the change from a postnatal to a fully prenatal scenario, and therefore a lot of things will change.
Yes, I agree with you. I have the same experience as you, Katja. Until I think 5-6 years ago, I did not know Kabuki at all, and then we started off with exome sequencing in our center, and then I had, if I diagnosed the left hypoplastic heart syndrome, I think 1 on 3 had Kabuki syndrome, or more somewhere in that. I have to look into my database, so I do this by the top of my head, but very frequent syndrome in left hypoplastic heart syndrome. And then I was wondering, how does this come? And if I look at my Precor registry, if you see the babies that demise, I really think that those babies demised on the ICU without ever being tested. And that are things we really should realize. That is also that I did not include in my talks now, but to predict outcome. A lot of people look into the literature and take publications of pediatric surgeons. But if you diagnose a heart defect at 13 weeks, or let's say 20 weeks, there is still 20 to 25 weeks until a baby is lying on the operating table of a surgeon. And in those 24 weeks, so many things can go wrong. And that is, I think, the most important message of these two talks, is that I think if there is nothing other available, of course you use that. But always think that the baby still should survive those 24 weeks. So you should be modest, and don't one by one translate those numbers into your room at 20 weeks. At the last slide, I put a drawing of a single outlet, and that is also an example. If you look at how is the name, Katja, when you have only one
truncus arteriosus.
Truncus arteriosus.
Okay.
If you have a truncus arteriosus, I got a little blocked. If you look at the outcome of a truncus arteriosus from a surgical point of view, the survival is quite good. But I looked at a cohort of truncus babies from 20 weeks onwards, and then only 1/3 was operated because there were so many things going wrong between 20 and 20 weeks and lying on the surgical table. And I think that is an important message to bring to the people.
Well, I was quite interested to the meaning of the bird that you showed on your last picture.
That's a bird with big eyes. Always look good to your ultrasound pictures, and always look critical to scientific data.
Yeah. Okay, I understand. Yes, I think also that regarding your talk on the obstetrical complication and the obstetrical management, that this is something which varies a lot from one country to another. I think that in the Netherlands, in general, women are less prone to terminate the pregnancy for heart anomalies, and that they listen to the obstetricians, and we have also quite a cooperative pediatric cardiologist that will agree on not having these women delivered by C-section. But I think that in Italy, for instance, the situation may be completely different. Can you tell us something, Francesco, about that?
Yeah, so it also depends upon which part of Italy you're from, because Italy is a country with a lot of diversities, and the termination rate for cardiac anomaly is very high. Unfortunately, it's very, very high. It might be lower in the southern part of Italy, but I think in the central and northern part of Italy is still very high, and especially because not all the centers have a joint connection between pediatric cardiologists, neonatologists, intensive care unit specialist, and obstetrician, and this is most because of that. And I would say, unfortunately, because a huge part of the assessment of women in pregnancy in Italy is private, is private practice. So there is no general rule that you should send a patient to a specific center. So I would say most people, they do that, but it's also a significant proportion of obstetricians they just deal with the patient on their own. They just provide their own counseling, and so there is no a formal reference. So there is no a formal network which allows referral towards, let's call, university center, bigger center, in order to have more objective diagnosis, prognosis, patient discussion, and management.
And what about the percentage of C-section in these patients?
I would say, I'm not saying 100% because not 100%, but it's very high. Of course, it
Because
depends.
one may fail to arrive at the operating theater and deliver before.
Yeah, because it's because also I would say most of the cardiologists says that for the organization they prefer to have the patient delivered by cesarean section because everything is done in the morning, or because in some parts of Italy the hospital in which there is a pediatric cardiologist, so the pediatric heart surgery service is not an hospital in which women can deliver. So they actually sometimes organize delivery in this hybrid room, in which there is, of course, in this case, they do not allow for vaginal delivery, and they prefer to go for cesarean section straight away. I would say the percentage of cesarean section, at least for the most severe condition, it's almost 100%.
That is really a pity, and I do understand that healthcare systems differ. But if we look back to our Amsterdam-Leiden cohort, we saw that the more we did in predicting, and the worse the neonates went because of pulmonary hypertension.
Yeah.
And I'm talking about the transposition babies now.
Yeah.
And we have just since 2 or 3 years, that is the work of Dr. Van Palen, introduced that specific table I showed on that slide, in which we give the babies oxygen first and keep them on the cord, so delayed cord clamping, and that results in having the baby on the mother's chest for around 15 minutes to have that quarter of a golden hour, and with that reducing Reskins, because I think it is already, there are several reports in literature that Reskins also induce lesions of the neonatal brain. And I fully understand, because I know that in other parts of the world, the pediatric hospital and the obstetric hospital are not even in the same building. So I really do understand the differences in healthcare systems. But on the other hand, it is important that as a community, we should realize that the more we do for certain cardiac defects, we also create morbidity in those neonates.
Yeah.
I agree with you extremely, and I think that this is a very important point, Monique. I think that the mistake that we maybe made in the past is that we don't allow the babies to go through a normal transition.
Exactly, that is what I mean.
Yeah, so we jump in and do the Rashkin before they've even transitioned. And I think, you have to allow that process to happen before you decide if the Rashkin procedure really is necessary or not.
But that are very new insights, I think.
Right. Very interesting.
Yep.
So do we have any question from the audience?
Don't think so. Let me check. No. Either most people were satisfied with all the presentation.
Yes, I think so too.
Is there any burning question from the panel?
Not really, but I think that Kabuki syndrome is an incredibly good example of why we must not stop with the at our QF PCR, and rather also consider doing a whole exome sequencing because I the same as Monique have had lots of examples where I know that if the parents had known that the baby had Kabuki syndrome, they may not have continued with the pregnancy. And I know also babies that spent 6 months in hospital, never went home, and finally died that had Kabuki syndrome. So I think we cannot underestimate the importance of doing the genetic diagnosis, if possible.
Yeah.
Very important point.